Good evening, doctors. I'm Manit Mandal, Marketing Head of Inspire team on behalf of Lupin Limited. Takes pleasure to welcome all the distinguished delegates, eminent speaker for today's webinar. I'm glad to meet you all and hope all are healthy and fine. Talking about today's evening, Lupin has always been a catalyst and frontrunner in the fostering scientific and advanced medical knowledge by partnering with leading association and university across the world. Continuing our endeavor today, we are proud to present the inaugural webinar of ADA 2023 chapter. The chapter speaks majorly about overcoming clinical inertia to insulin initiation and insulin intensification. It is going to be a module-wise learning approach along with leading KOLs of India and, of course, international KOLs also, wherein the HCPs will get an opportunity to learn and understand the challenges area in the field of insulin management. I'm proud to share that Lupin has exclusively partnered with American Diabetic Association to bring this advanced medical knowledge to distinguished HCPs like you. I welcome you all in this endearing academic session. Talking about Lupin once again, in the space of anti-diabetic therapy in India, Lupin has consistently maintained leadership position by having a comprehensive basket with necessary products, and shall continue to contribute to the well-being of the patient in year to come. With this, I would like to conclude by thanking you all and look forward to your active participation in this particular program. Very thank you, and over to Dr. Vivek for the further proceedings. I think Dr. Vivek, you're on mute right now.
Yeah, thanks Manit for setting the tone for the meeting. So once again, welcome all, and a very good evening to all of you. On behalf of Lupin's Inspire team, I, Dr. Vivek Kolapkar, take this pleasure to welcome you all for today's ADA webinar on one of the very important and I would say a crucial topic when it comes to insulin, which is the clinical inertia to insulin initiation and intensification. Well, you all must be knowing that despite these newer agents which are come into the foray, including the SGLT2s as well as the GLP-1Rs, if you'll see the recent data, especially from the ICMR INDIAB study, still 64% of the patients, they do not achieve their glycemic goals. And one thing which is striking in this study or in this paper is that only 11% of the patients are on insulin when it comes to managing patients with diabetes. So this topic of overcoming clinical inertia is very important. And to take us through this and how to tackle this clinical inertia, as well as all the nuances related to insulin initiation, as well as intensification, it's a great pleasure to welcome our today's international faculty, Professor Dr. Guillermo Umperez. Welcome, sir. Thank you so much for being part of today's program. So Professor Guillermo doesn't need any introduction. He is one of the professor of the medicine in the Division of Endocrinology, University School of Medicine, Grady Medical Hospital Clinical Research Network, as well as he's a director of Diabetes and Endocrinology section at Grady Memorial Hospital. He is a teacher of teacher, and he is recipient for the award like the best clinical teacher and best mentor of endocrine fellows. He is also a member of the prestigious organizations like the ADA as well as the ACE. He is an avid researcher with and has a publications of more than 200 scientific manuscripts and book chapters. Along with that, he has also presented over 180 research abstracts at various national as well as international conferences. So with this, without wasting any further time, I would request Professor Guillermo to please start the proceedings for today's meeting. Over to you, sir.
Thank you so much, Dr. Kolapkar. And I hope that I can share my screen. It is such an honor to be with you today. And of course, as you mentioned, this is one of the major deficiencies that we have in diabetes care, the treatment inertia and the slow pace of starting and intensifying insulin therapy. So here this slide shows the learning objective. We're going to discuss how do you choose the right insulin according to the patient that is in front of you. We're going to discuss among the different basal insulins. When would you progress from basal insulin to basal bolus? Or perhaps basal insulin together with non-insulin agents. So Have you mentioned, Dr. Kolapkar, is that 50% of patients do not achieve good glycemic control. This is data from the United States published 2 years ago. When you're looking here to the right, is that less than 50% have a hemoglobin A1C less than 7. And somewhere around 30–40% remain with hemoglobin A1C greater than 8. And since 1990 to the year 2000, 7 has been the goal for most of the clinical trials. So to the left are all of the different medications that we have for treatment of diabetes. Most of them are oral agents, metformin, sulfonylureas that we have learned to use throughout the years, new compounds, but insulin is needed in most people. This is data that came from the United Kingdom Prospective Diabetes Studies, and this was published 20 years ago. And what you have in here is that at the time of diagnosis of diabetes, we believe, and it has been estimated, that we have lost 50% of the beta cells or the capacity to make insulin. And with increased progression and duration of diabetes, there is a decrease in insulin secretion. The beta cells of the pancreas are genetically engineered to undergo apoptosis or cell death. So if you have a patient with short duration of diabetes, you can use oral agents. Yeah, it works. That if you have a patient that will have more than 8 to 10, 15 years of diabetes, especially if they have not been well controlled, insulin is needed to achieve glycemic control. So unfortunately, as we mentioned before, and Dr. Kolapkar already mentioned to you, that a large number of patients remain with hemoglobin A1C greater than 9, what we call very poorly controlled. 1 out of 2 patients would have hemoglobin A1C greater than 9 are started on insulin. And we play this role of 1 agent going to 2 agents, going to 3 agents. But if you have 2 agents and you add a third one, the reduction of hemoglobin A1C is very little. Because especially in those patients who have long duration of diabetes, the beta cells of the pancreas are not there. So insulin therapy is indicated in everybody who has polyuria, polydipsia, and weight loss, because they are in the catabolic state and you have to stop the catabolic state. It doesn't mean that you're going to need insulin for the rest of your life. If you present with newly diagnosed diabetes, then you can change them, but you have to break what is called glucose toxicity. Everybody with type 1 diabetes and people who has been on 2 or 3 oral agents, adding insulin is the way to go. So the question is how you do it. These are the recommendations of the American Diabetes Association. I apologize for the poor quality, but this is how the best I can download from the ADA. So the ADA 2 years ago, I was president of ADA and being on the board for many years. We says if you have 2 oral agents and you are considered to start an injectable, you should do a GLP-1 ahead of basal insulin. Why? Because GLP-1 have been shown to have cardiovascular and renal protection and no risk of hypoglycemia. That if you have GLP-1, you can add basal insulin as an alternative. Or if the GLP-1 is not controlling, add insulin. Because the combination of insulin and basal and GLP-1 really work in improving glycemic control, in preventing short and long-term complications. So, basal insulin. This is what we have since 2015. Now we have even more. So, basal insulin, you have human insulin. It can be NPH. Still a very good insulin. You can have basal analogs. You have glargine, detamir, and biosimilars. And you can have what is called ultralon, although we will discuss in the next few minutes that we are coming in the next future, possible next year, with weekly insulin. But what we have with ultralon insulin, we have U300 glargine and degludec that comes in U100 or U200. So when you look at the clinical characteristic and pharmacodynamics, we know that NPH has been around since the 1950s, so 80 years ago. And it works in 2–4 hours, has a peak. And this is why we have hypoglycemia, but the effect is great. You have glargine and deramir and biosimilars with a duration of action about 24 hours. Glargine U300, more than 24, and degludec, the longest active, up to 42 hours. So how we do it? So most of our patients, we start with 1 or 2 oral agents, and if they have increased hemoglobin A1C greater than 9, you start insulin. And you can start with NPH and biosimilars. Or you can start with glargine or deramir or degludec. And the goal is to continue the oral agents. And if you use NPH, you should always do it at that time. If you use basal analogs, you can do it any time of the day. And what we recommend is to start in the low dose. You don't stop the oral agent, they still work. But you're going to start at the low dose and you're going to increase the dose progressively because we don't know what is the requirement of each individual. And you're going to increase the dose, and we tell the patient to increase 2 units every 2 days until you achieve goal. And you keep the oral agents. So how good is NPH? The study is now on old, but it's very practical. That compare in NPH insulin once a day, twice a day. You get a reduction of 2.5 in combination % of hemoglobin A1C in combination with metformin. If you use it with sulfonylureas, you get 2% reduction. Here is a catch. Sulfonylureas still work. And if you add insulin, the increased risk of hypoglycemia. So I try to avoid using sulfonylureas with insulin. If I'm going to use insulin, I can increase the dose of insulin and I can assure a progressive decline of hemoglobin A1C. But if you use with sulfonylureas, there is an increased risk of hypoglycemia. So NPH works well in combination with metformin. So if you compare NPH with basal insulin, here to the left is with glargine U100 and to the right is with deramir. And exactly the same. So why? It's because these are treat-to-target studies. If I tell you to increase the insulin dose to bring the fasting blood glucose less than 100 or 110, you're going to decrease hemoglobin A1C in the same level. And it doesn't matter if you do glargine or you do deramir. But the problem is NPH has a peak. So if I give you NPH at night and I keep going up and going up to decrease fasting blood glucose, I will increase the rate of hypoglycemia in about 30 to 40% compared to glargine or deramir. So if I'm going to use NPH, I'm not going to try to get a fasting blood glucose less than 100, 110. I'll be satisfied with maybe 140. In that way, I can reduce hemoglobin A1C, like shown here to the left, but I prevent the rate of hypoglycemia. So if you're going to use basal insulin, you're going to start in 10 units, and I'm going to tell the patient to increase by 2 to 4 units every 2 to 3 days. The American Association of Clinical Endocrinology, we just published our guidelines, which says, look at the hemoglobin A1C. If the hemoglobin A1C is less than 8, you start at 0.1 to 0.2 units per kilo. If it's more than 8, 0.2 to 0.3 units per kilo. So somebody like me, I would start myself somewhere around 10 to 14, 15 units. And I will increase the dose every 2 or 3 days by 2 to 4 units until I achieve the goal. That is with the basal insulin, glargine, deramir of NPH. What about the long-acting, the longer-acting? What we used to call ultra-long. Now, I guess we have weekly insulin, ultra-long. So glargine U300 and degludec is flat, the effect. It has less hypoglycemia compared to U100. And the duration of action is between 36 or greater than 40 hours for degludec. So the studies have been done. The U300 is called the addition program, comparing U300 with U100. And there is no difference in hemoglobin A1C. Again, why? is because there's a treat to target. You're going to increase the dose of insulin until you achieve a fasting blood glucose less than 100, 110. But if you look at the rate of hypoglycemia, similarly, what I show you between glargine and NPH, you have to have a significant reduction in the rate of hypoglycemia, especially nocturnal hypoglycemia. So if you have a patient with type 1 or a patient with type 2 who is at risk or having hypoglycemia, a good strategy would be to change from U100 to U300 or to degludec. So these are studies comparing glargine, U100, to degludec. And here you have, it's a treat to target. You increase the dose of insulin until you bring the blood glucose, fasting blood glucose down. But at the rate of hypoglycemia, here to the right, in the red line is degludec, in the black is glargine, you have a 20-30% reduction of hypoglycemia. So if you have somebody on U100 and you having hypoglycemia, this is a good alternative because you reduce the rate of hypoglycemia. So if you only use basal insulin controls your blood sugars in between meals, especially at night. A problem with type 2 diabetes is that the liver makes too much sugar. It's an exaggerated glucose production by the liver. So that's what you use metformin. But metformin doesn't control the postprandial. Basal insulin doesn't control the postprandial glucose excursion. And what I'm showing here is that every time we eat, our glucose goes up. And in a patient with diabetes, the higher the hemoglobin A1C, the greater the peaks after a meal. So unfortunately, when we start oral agents, metformin, DPP-4, we add basal insulin, we don't achieve goal because we don't cover postprandial. So the American Diabetes Association will say, okay, to cover postprandial, we have to give rapid-acting insulin before meals. But I don't know, how would you feel if somebody tells me that I have to give one injection before each meal? Would be a tremendous burden. So the American Diabetes Association would tell to take the basal insulin and to just add one rapid insulin injection before the largest meal of the day. So for me, it would be at night because dinner I have with my wife and then that's my largest meal. I would start there and you just give 10% or 5 units before dinner time. And if that's not enough, I'll go to a second or even a third largest meal. It is clear to me that there are several people with diabetes who are overweight, obese. They have 3 largest meals. So this program doesn't work if you have 3 largest meals. But for people, most people, they have one single large meal. So that's when you start the basal insulin. So, and you progress. And if you compare from the beginning, start 3 shots, or you just go 1 second or third, it's no difference a longer duration after 24 weeks. So this is a good strategy. You give basal, you have rapid acting insulin before meal, you start on the largest meal, and you progress as needed. The other alternative is to use pre-mixed insulin. And I'm aware that in India, pre-mixed insulin is commonly used. Same thing, 14% of my patients with no insurance are on pre-mixed insulin. And of course, it has NPH and it has regular. So you start, and it works as well as basal insulins. And these are just 3 different studies. And what you're looking at is a reduction of hemoglobin A1C, and it's the same. But you can imagine if I use premix, there is an increased risk of hypoglycemia, the same as if you use NPH, because it's NPH and regular. So these studies, again, has a target less than 100, 110 milligrams fasting blood glucose. That's not the case. If you are going to use 70-30 insulin, you are not going to go for tight control. Slow down. Just fasting blood glucose. Maybe target should be 130, 140 to prevent hypoglycemia. It worked well in reducing hemoglobin A1C, that it has an increased risk of hypoglycemia. So in our university, we increase insulin. If it's 110 to 140, you increase by 2 units. If I have an older adult, maybe 140 to 180, I'll increase. So you have to individualize therapy. So you start on basal, you can go basal +1, +2, +3, rapid acting, or you switch to premixed insulin. But now we have GLP-1 receptor agonists. You have the daily one, liraglutide, and we have weeklies, dulaglutide, semaglutide, and tirzepatide. And adding a GLP-1 has an additive effect to the basal insulin. GLP-1 slow down gastric emptying, so decrease postprandial. It suppress glucagon secretion, so decrease hepatic glucose production. So stimulate peripheral glucose uptake, both basal and GLP-1. And GLP-1 by itself does not increase the rate of hypoglycemia. And in addition, what we have learned is that the use of GLP-1 is associated with weight loss. Now, you have seen the semaglutide, the Ozempic, the tirzepatide. But studies have shown that if you go from glargine to basal insulin, you increase body weight. And the combination of basal insulin with GLP-1 is not associated with weight gain. And maybe you lose a few pounds. And the other thing is that here you have to the left the combination of insulin with the GLP-1. To the left is reduction of hemoglobin A1C. You get an additive effect. Why? Because GLP-1 control postprandial, control hepatic glucose production. And insulin, of course, we already talked that it works by suppressing hepatic glucose production and increased glucose utilization in peripheral tissues. Here in the middle, several studies have shown that you don't gain weight, you even lose weight. And more importantly, you significantly require less insulin, shown to the right of this slide. So the combination of insulin plus GLP-1 is for sure my favorite. Or you start with GLP-1 and you add insulin, or you just start insulin, you add a GLP-1. And then you decide if you do a weekly or a daily injection. You can also, to control postprandial, you can do a DPP-4. It's less potent, but it's oral. Here you have to the left, it changes in hemoglobin A1C, and to the right, no difference in body weight. Same thing with SGLT2s, especially in those patients who have history of heart failure, high cardiovascular risk. The use of SGLT2 is indicated. In a patient who has chronic kidney disease with proteinuria or a GFR less than 60, they must be on SGLT2. So if I look at how we have progressed during the past 30 years of insulin therapy. So we start with metformin, you add second or third agent, you decide to do basal. You have two pathways. Or you can go for the pathway or 70-30 or multiple injection. This is what we used to do. I believe right now, if I have somebody on oral agents plus basal insulin, I will use a GLP-1, a DPP-4, and SGLT2s. This is what you should take home, is these two pathways when basal is not enough. So just for completion, we believe that the FDA is now reviewing the data, and now we have 2 weekly insulin. So instead of getting an injection, multiple daily injections today, just take 1 injection. And Novo Nordisk and Lilly are both working on these products, and both are equally effective with data recently published. This is data published about a couple of months ago, comparing to glargine U100 with the Novo Nordisk, is called Icotec. And what you see here is levels of glycemic, the hemoglobin A1C up to 78 weeks. No difference. Here is, if you use CGM, the percentage of blood glucose within 70 to 180 shown in the green, no difference. And percentage of people who achieve hemoglobin A1C less than 7, no difference. So taking an insulin once a week appears to have similar effects in controlling blood glucose than the daily insulin. As I mentioned, I showed you just data with the Icodec. Lilly also has a phase 2 just published a couple of months ago. And these insulin have a long half-life. And multiple studies have shown that the control of glucose in green is glucose between 70 to 180. In green and yellow and orange is more than 180. And the red, no difference in hypoglycemia and no difference in hyperglycemia. And of course, people says, do you want to have an injection every day or once a week? But most people say, give it once a week. That's the same thing that we have with the GLP-1. Liraglutide works well, but it's daily. Semaglutide, dulaglutide is once a week. So most people are mostly satisfied with the once weekly insulin compared to daily injections of insulin. So I hope that I provided to you a rationale. How do you start? How do you select the perfect or the most convenient insulin? Nobody can tell you which one you use. They all work by decreasing hemoglobin A1C. The human insulin, NPH 7030, has a little more hypoglycemia, so target should be different. The basal insulin first generation, the Glargine G100, the Levemir, works well. The U300 and Degludec have a little less hypoglycemia. So then you're going to start oral agents, you add basal. But we know that 40% need something else. And this something else could be rapid active insulin or rapid insulin before meals. Or it can be 70-30. Most recently, we prefer to combine insulin with GLP-1 receptor analog because of the beneficial effects, not weight gain, less hypoglycemia, less insulin, and cardiovascular protection. I cannot stop before telling that SGLT2s is also a convenient way to basal insulin, especially in high cardiovascular risk patients and patients who has chronic kidney disease. Every single patient with chronic kidney disease or a history of heart failure should be on SGLT2s with or without basal insulin. I really thank you for the opportunity to be with you, and I hope this information will be of benefit. Thank you so much.
Thank you so much, sir, for this wonderful presentation and also highlighting how to initiate insulin as well as how to intensify. So there are some questions from our audience. So the first question is regarding the use of insulin. So when we initiate insulin, which insulin to be used for which patient? So if because the Indian guidelines also mention about, and even the ACE also talks about premix for initiation. So when we have to decide on basal or premix, how do you decide?
So the number one insulin around the world is Glargine because it has been around for over 20 years. So in 2003, in 1993, in 2003 was that paper from Matt Riddle, which told us about this basal insulin. So that's why I use basal insulin. In our hospital, we use Levemir because of cost. And at Emory University, depending what clinic I'm attending, we use Glargine. You can also use Degludec. There is no difference. It's no different. And if a patient doesn't have insurance, I still use human insulin, NPH, because of cost. In the United States, and I know in India, your insulin are not very expensive, but in the United States, starting next month, we have a cap of insulin. We work with the government, and there is a cap of $35 a month. I understand $35 is a lot of money in India for pay for insulin, but we used to pay $200 and $300. So which is the best insulin? It's whatever the insurance can cover. Depends on who is in front of me. If they have insurance, no insurance, they use NPH or 70-30 twice daily. I start low dose. That's the message. But we teach the patients to increase the basal insulin every 3 days or every 2 days, 2 or 3 days, slowly. We start at a very low dose because we want to prevent hypoglycemia. If the patient gets hypos, the patient gets scared. So we're going to increase slowly until we achieve fasting glucose and hemoglobin A1C values. Now, the target is your job. You have to decide. If I have an older adult, I don't have a target of 110. If I have a type 1, yeah, I want to have a hemoglobin A1C less than 7. If I have a patient with chronic kidney disease, if I have a patient we already have hypoglycemia, so you have to decide the target for each individual.
Right, sir. So next question is regarding the very important one regarding monitoring. So how to monitor when we initiate basal insulin, especially when we are using it with along with the oral agents, and whether we should only check fasting or both fasting as well as postprandial. So what is your opinion on monitoring?
And this is the major problem why we don't achieve glucose control. Basal insulin cover overnight fasting blood glucose. So if I'm going to adjust my insulin, I'm going to look for basal insulin, I'm going to look for morning blood glucose. But I know that if I have a good fasting, but hemoglobin A1C is still high, I know the problem is postprandial. So oral agents that cover postprandial, DPP4, SGLT2 somewhat, but GLP-1. Or I can go to multiple injections. So if I have to decide going to one injection per week or daily, most people prefer once a week. So I'll use long-acting GLP-1. But I can also use DPP4. I can also use an SGLT2. So if you look at the fasting blood glucose, and if the blood glucose is okay, the problem is postprandial. The other trick that I use is look at the blood glucose at bedtime and the fasting blood glucose. So if I drop the fasting more than 50 milligrams, what it was at night, maybe I'm jumping and I'm increasing the risk of hypoglycemia. And remember that 50% of patients have asymptomatic hypoglycemia. So 50 is more than what you really want. You just want to have a blood glucose. So somewhere around, to me, 100 to 140 is what we use at Emory because we want to prevent hypoglycemia.
Right. So a couple of questions regarding use of insulin along with the oral agents. So what are those precautions or what are those clinical considerations one should take care of when you are initiating insulin with OADs?
So most patients are on metformin, DPP4, metformin, sulfonylureas, at least in the United States. And if I'm going to add insulin, if I'm using metformin, DPP4, SGLT2, I just add insulin and they progress. If the patient is taking sulfonylureas, then you don't know how much sulfonylurea is working, but you cannot know how much, if you add insulin, the risk of hypoglycemia doubles. So I try to avoid insulin plus sulfonylureas as much as possible. I may require a few extra units of insulin. Yeah, because sulfonylureas work by increasing insulin production. But if I'm giving insulin, maybe instead of 14, I use 18 units or 20 units. But I can adjust insulin to achieve my level of glycemic control.
Just another question regarding the use of insulin early. So we know that there is this concept of early insulinization. So when one should consider using insulin early, maybe even at the start or at the diagnosis of type 2 diabetes?
So anybody who presents with weight loss, polyuria, polydipsia, glucose, elevated blood glucose is a candidate for insulin therapy. And we have somewhere around 250 patients admitted every year to my hospital with blood glucose greater than 400. And what we do, we start metformin and basal insulin. We're going to break what is called glucose toxicity. And I increase the insulin to bring the blood glucose down. And somewhere around 2 to 4 weeks, most people break the glucose toxicity and regain the ability to make insulin. And I can start decreasing the dose of insulin and maybe add a DPP-4 other agents to cover postprandial. And about 70% of these patients are off insulin within 10 weeks. So if you have a newly diagnosed patient with glucose more than 400, we present with polyuria, weight loss, I start metformin plus basal insulin. And I start on 0.2 units and I increase the dose until the glucose comes down. That resolves glucose toxicity. And then in somewhere around 8 to 10 weeks, most people are off insulin. Now, if the patient has type 1 diabetes, a history of GKA, different story. Likely they require long-standing insulin therapy.
Right. So one last question regarding, although we know that insulin is to be given to a particular patient and he requires insulin, but how do you convince a patient to take insulin?
Well, I would tell the patients that taking insulin, we explain them that first thing I tell you is that I see somebody who is on 10, 15-year history of diabetes. I let them know that the amount of insulin their body makes after 10, 15 years of decreases. They need insulin to help the oral agents to work. The oral agent, the injection is still working, but they need a little help. And again, I would start with the small dose. The main fear is I don't know if that happened to you, but I was traumatized as a kid with these injections that I got intramuscular. So people had that thing always going to hurt. So we teach them in the clinic, our nurses are, or educators, teach them that the insulin really, it doesn't hurt. And we tell them that taking insulin is significantly less painful than pricking your finger to control your blood sugar. So most of the time we're convinced them, but of course once in a while we get no insulin therapy, but we have GLP-1s. But it is the daily challenge that you and I have, that's right. But if with good education and we convince them we're going to start at a very low dose and we're going to adjust to achieve goals, most of the time we're successful in initiating insulin therapy. Again, which one you use depends on access. Goals depends on who is in front of you. 3, please use insulin. If you have 2 or 3 oral agents, just adding more doesn't do much. You just need 1 dose of insulin.
Right. So one last question regarding use of insulin. Basically in patients who are hospitalized, so which insulin to be used? Can we use basal insulin as well in hospitalized patient as well as in comorbidities like CKD? How do you go about with the insulin therapy?
So in the hospital, we in patients who have glucose greater than 180, yeah, no question, basal insulin is the way to go. And then in patients with chronic kidney disease, we use very little doses, 0.1, 0.15 units per kilo to prevent hypoglycemia. And then we decide at discharge, are you going to continue or not? So thank you so much. And Nico and your group are fantastic. I love your introduction, Dr. Kolapkar, and hope to meet you in the near future.
Thank you so much for your time and also for this wonderful session. I hope all our doctors have enjoyed this presentation. Thank you so much.
Take care.
Take care, sir.
Bye now.